Now, I'd first of all like to start by acknowledging the traditional owners of the land we're meeting on today, the Wurundjeri people of the Kulin Nation. We pay our respect to their elders past, present and emerging. And hello everyone, and welcome to our Western Health webinar on diagnostic pathways for children suspected of autism spectrum disorder. My name is Gillian Head from the GP Integration Unit at Western Health, and we have here today paediatrician Dr. Mandira Haramath, who will be delivering this evening's session. And just a bit of housekeeping from me before we start, so please keep your microphones on mute during the session, just to minimise any background noise and distractions. And we also have our GP advisor, Dr. Jo Silva, here with us this evening, so she'll be facilitating the Q&A. Please type your questions in the chat box during the session, and your questions will be answered at the end of the session, so we'll leave sufficient time for that. And please also ensure your name in the Zoom meeting is correct, because we need to acknowledge who is in the session in order to allocate the CPD points. And we have Phil here in the background who I believe he's going to be sending a link around to the evaluation survey in the chat box. So I encourage you all to complete this. It helps us to improve future sessions. So I'll now pass over to Mandira to commence the session today. So over to you, Mandira. Thank you.
Hi, Jill. Thank you so much for that introduction, and thank you for allowing me to speak this evening. So my name is Dr. Mandira Haramath. I'm a paediatrician. I work at Western Health. I mainly work at the sites of Melton Health and also Bacchus Marsh Hospital, where we do a lot of this work on autism spectrum disorder. So today I thought I would present an overview about autism spectrum disorder and go through the diagnostic pathways and how we do diagnose and get support for children suspected of having autism spectrum disorder. Sorry. So we've already done an acknowledgement. So during this presentation, I'd like to give you a bit of an overview of autism spectrum disorder. So that will include what does autism spectrum disorder actually mean and what does it look like. This will include going through the DSM-5 criteria for diagnosis. And then following that, we will go through a couple of the pathways that are commonly explored for diagnosis by families. And then through that, we will talk about the specific multidisciplinary autism assessment run through Melton Health, which is based on the gold standards as determined by the Autism CRC, which is a national body that kind of governs this area. At the end of the presentation, we'll leave about 20 minutes to 30 minutes for question and answer time. So during the presentation, if any questions come up, please write them down or type them in the chat box as discussed by Jill, and we will definitely try and go through these at the end. So starting off with what is autism spectrum disorder? So autism is a group of developmental disabilities that can cause significant social, communication, behavioural challenges. And as the title suggests, it is definitely a spectrum, and each child is affected differently. I've been working in this field for approximately over 7 years now, and I've never met one child who presents exactly the same. And this surprises a lot of families that we see because they have one child that may be diagnosed with autism and their second child or third child might look slightly different, and they don't feel like it is autism because these children look so different in the way they present and their behaviours and their difficulties and strengths. So I think that's really important to keep in mind because the presentation varies so much. Autism is rising in prevalence in our community, and there are many hypotheses that are surrounding this. Is it just because we understand it a lot more? Is it something to do with the environment that children are now raised in? So the cause is really largely unknown, but at this stage, evidence shows us that approximately 60% of it is secondary to genetic conditions. And as illustrated in this image on the right, Approximately 50% of that is inherited, and then sort of approximately 10% are new variants that are presenting themselves. And then the other 40% is secondary to environment, and that can be exposure to certain things in utero. It can be secondary to infant mental health and the environment around a child's early life. And it can also be what sort of parenting and family structure and things like that the child is exposed to as they get older as well. So there are lots of contributing factors to autism spectrum. So in Australia, we mainly use the DSM-5 criteria to guide our diagnostic process, and this is because there is no one test that is a gold standard for testing for autism. So the DSM-5 criteria is a really good framework for us to go through and see if the child meets the criteria. So I will go through each one of these points one by one with some examples of what that might look like in children of different ages. So the first criteria is deficits in social emotional reciprocity. And so this is how a child socially and emotionally connects with the people around them, and that includes their family and their peers. So difficulties that we look for in this area are what their verbal language looks like. So do they speak with any accents? Do they speak in an unusual intonation of voice? And that can be using a baby voice at times, a baby toned voice at times, in a situation that's not appropriate. So there's a difference between a child just seeking attention and so putting on a different voice versus a child just spontaneously talking in an unusual intonation of voice. Some children might speak unusually high-pitched, low-pitched, loud, soft. So we're looking at all different characteristics of verbal speech. Some children may not speak at all, and obviously, as well as exploring speech delay, they may present as mute because of an underlying autism present. They may not respond when spoken to, and this is one of the most recognized features of autism, where families say, I keep calling my child by their name and they just don't turn. I have to repeat their name over and over again. Or a classroom teacher will say, I say their name over and over again and they just don't turn. These children struggle to use back and forth conversation. This can be hard to detect in the toddler years. Because toddlers up till about 4 years of age, they don't really have this skill cognitively to ask questions and hold a back and forth conversation. But by the time the child's approximately in primary school age, so about 5 or 6 years old, we expect them to be starting to ask questions back. So, for example, if you think about when you go to a dinner party, you sit down next to somebody and you ask them, so tell me about yourself. What do you do? What do you like? What are your hobbies? You make conversation and you show interest in the person sitting next to you. Someone with autism or a child with autism will struggle to do this. A lot of them hold excellent conversations when it's a topic about what they're interested in. And in a lot of children we see these days, this is video games such as Minecraft, Roblox. It can be about Pokemon, dinosaurs, and it really depends on what their interest is at the moment. But when you offer information about yourself, for example, saying, I like going to the beach, they will not know how to follow up on that statement. And so conversation can be very one-sided. And often families will feel this as well. They will say, look, I tried to ask him about school, but he doesn't respond to me. Or, he never asks me how I'm feeling. And those are the sort of things that we need to keep an eye out for. They have difficulty sharing in interests of others, and they also have difficulty in sharing emotions, and that's both their emotions but emotions of others. Some children have a very good knack of learned responses to emotions, so they might learn how to go over to someone who's crying and say, "Are you okay?" But the true empathy and that feeling that you get from a true emotional response might not be there, and those sort of questions might be a bit, again, a bit limited and not feel as natural as it would be for a neurotypical child. and they may not initiate or respond to social interactions. And this can be seen in the playground. So for children preschool age, asking questions about what do they do at a playground? Do they go and show interest in other kids? Do they watch other children running around? Or are they sort of just over in the sandpit playing by themselves? Or do they go over and say hello, but then they struggle to know what to do after they've said hello? So it's those real difficulties. But as you can see, as I'm talking through each of these points, there is definitely a spectrum to each point. There can be the very severe end where there's none of these feet, where there is no evidence of the child trying, but then you've got the higher functioning end of the spectrum where the children are trying to do these things, but they reach stumbling blocks. The second criteria is deficits in non-verbal communication behaviours. And so these are more the subtle signs of communication and can often, but play such a big part of a child's understanding and communication as well. So this includes inconsistent or unusual body language. For example, one of the biggest things is an understanding of personal space. So some children with autism may be over familiar with people. They may approach strangers, may go up to strangers and give hugs. They might go and start holding hands with you, even though you've only met them once or twice. They might come and stand very close to you. And so they just don't get that concept of personal space. But on the other hand, they're very protective of their own personal space. So if a family member comes in to give them a hug, they can tense up quite a bit, or that can make them feel very anxious. The second most common feature of autism that's recognised by the community is poor eye contact. And just because poor eye contact is not there doesn't mean that the child doesn't necessarily have autism, which is what some members of the community sometimes feel. And by poor eye contact, I don't mean just the lack of eye contact, but it can sometimes present as very intense eye contact where the child just stares without blinking, without looking away, which can also feel quite unnatural as well. Some children don't understand gestures, and this is a really good feature in the younger children, in your preschool children, where some preschool children, they do not point. So when they're developing their communication skills, where their verbal skills just aren't quite up to scratch as yet, lots of toddlers, especially neurotypical ones, will point to things, will come and get their parents' attention and will point to what they want. Children with autism struggle with this kind of using gestures to communicate. They don't imitate as much, so copying others, such as clapping. So when excited, they may not wave, they may not, clap with excitement, but they might show their excitement in other ways. And the other one is facial expressions. So either we can get a really flat facial affect or a facial affect that's always stuck in some sort of expression. So either the really smiley kid that's always smiling, and this kid comes across as, the parents are like, oh, he's always happy. Like, there's nothing wrong with him because he's always happy. And it's those children that don't have much variation that that can be a red flag of autism as well. Going into difficulties in developing, maintaining and understanding relationships. As I said, in the preschool age, this can be tricky because preschoolers and under fives are very sort of egocentric. And so their play can be very parallel play, parallel play, or very sort of, wanting to play their own games. But as a child gets older and cognitively more advanced, you start to expect a neurotypical child to show interest in other children, want to make friendships, start to explore the concepts of having a best friend, and what it really means to have a group of close friends. We find with children with autism, they either don't show an interest in having friends, so they're very happy to play independently, and they might tolerate some children who come in and join in their play as long as they're playing what they want. But if those children want to play something else, they won't necessarily go along with those children. They'll prefer to just stay with what they're doing. Or you've got the children that don't fully understand what friendship is, and they think that everyone is a friend. So when you ask them, how many friends do you have, they list off their whole classroom. And that again is showing that a 5 or 6 year old doesn't really understand the concept of a friend versus a peer. And this is sort of, we expect this development as children go through primary school. And due to their previous difficulties, they have difficulty making friends. They may not also be socially appropriate. So as I said, with their emotions, they struggle to know what's emotionally and socially acceptable. So they might go and, be quite bossy. And obviously for children, that can be a very sort of negative thing in when you're trying to make a friend. So with a bossy child, those children may not be as socially appropriate as we would like them to be. And then the other thing that makes making friendships quite difficult is not engaging in imaginative play. So because these children are very, very reality focused, they may not go along with play that expects imagination. And this can include, games of fairies and witches or Dungeons and Dragons or whatever children would like to play. They might struggle to fit into those imaginative scenarios because in their world and in their mind, it's a very reality sort of focus. Sometimes clinicians get tripped up, I guess, by imagination, because a lot of children with autism will see a lot of imaginative stories on TV. So they will see things like Pokemon, and they will see stories about witches and fairies. And then they will take these scenes from television and reenact them in their play. And so parents come and say, he's got a great imagination. He reenacts Pokemon scenes all the time. And that is not true imagination, because that is something that the child has in their reality seen from the TV, and then they're just reenacting that or different versions of that. And that can often be a tricky part to pull apart. So that is the social communication part of the DSM-5 criteria. The second part is the restricted and repetitive behaviours, interests or activities. So the first part of that is your stereotyped or repetitive motor movements. So this can present in lots of different ways. For younger children, what families often notice in this area is lining up of toys. So as I said, because imagination can be quite limited, children will tend to play with their toys by organising them. So this can include making lines that stretch from one side of the house to the other side of the house, or colour coordinating toys, or sorting them into different categories, or so organising. And that can be a repetitive or very stereotyped type of play. Bursts of that in neurotypical children are fine, but what makes it concerning about autism is this feature of lining up toys. It continues. So it's not only on one or two occasions, it's a repetitive type of play. The other thing with this kind of play is children with autism can get very upset if this kind of play is disrupted. So if a parent or another sibling comes along and changes up the organisation, this can cause quite significant meltdowns, or the child with autism to go and just quickly fix it all back to make themselves, to regulate themselves again. Other movements we see quite commonly are hand flapping, and this can be in the situation of them being excited, anxious or sad, jumping up and down when excited, walking on their tiptoes. Head banging can occur when children are anxious, or when they're trying to fall asleep, or when they're trying to emotionally regulate themselves. Some children tend to have some unusual looking at things, so peering at things, where they can flip chairs over to see what's underneath them, hold cars up and observe their wheels spinning, and they can, or just, trying to really figure out the mechanics of how things work, and, really scrutinizing on how things are put together and really trying to pull that apart. They can also do a lot of repeating words or phrases, which is also called echolalia. And this is where parents are like, oh, he sounds like a stuck record. He says the same thing over and over again. So they might hear, a phrase on TV, and they might just repeat that phrase over and over again, completely out of context. And even if a question has been answered, they might repeat that same question. What we see as well is some children, even 6 or 7 year olds, when it's developmentally not so appropriate, they sing the same nursery rhymes over and over again, despite their speech not being as in line with their singing as well. The second part of restricted and repetitive behaviours is insistence on sameness, inflexible adherence to routines, ritualised patterns, or verbal or non-verbal behaviour. And this is the part where these children thrive on routine, and they really love rules. So this is the little policeman or policewoman that lives in the house or school, and they go around correcting all the other children or the family members on what to do, or if they've done the wrong thing. They need to have things happen the same way. So, for example, if a parent takes a different route on the way to school, they will quickly point that out, and they'll say, "Mum, why are you going this way? We always go that way. We need to go back that way." These are the children that need to have the same spot at the same dining table every day, or eat in the same bowl, same cup. They also, part of this is, a routine or very limited repertoire of food they eat, and they will need the same food prepared in the same way every day. And if they're not given this, they will not eat. Then you've got your highly restricted and fixated interests, which I touched on a little bit about before, but these children are the most amazing people in terms of when they get this interest, they know everything about this. I had one little girl who was super interested in animals and flamingos, and she knew exactly why flamingos were pink, because they ate shrimp, and she knew where they lived and what their habitat was and everything. And she was 4 years old. They take their interest to another level where a child their age, you wouldn't expect them to know such detail. These are the children that can list all the Pokemon, or however many Pokemon there are, all the dinosaurs, including how a Diplodocus is different to a Brachiosaurus, like they just know the teeny tiny details. But other things that you do expect them to know for age, such as their alphabet or, about other topics, they may not have much knowledge about that, because that is not what they're interested in. And really learning how to harness their interests and incorporate that into the supports and their strengths is so important when providing supports for children with autism. The other thing is they can get very attached to unusual objects. And so these are the kids that go around and collect, balls of lint from the house, or collect little rocks and have a packet of rocks sitting in their bag or their cupboard, and they just keep adding to those rocks, or whatever they're really into. And it can be little pieces of garbage or pieces of string, and it can be the most random things, but for these children, it brings them a lot of joy. And as I said, they will, if they're having a conversation, they will try and get that conversation onto their interest. So they can often go onto tangents to get onto their area of interest. The final criteria for restricted and repetitive behaviours is the sensory issues, and this is the part I feel that causes the families a lot of concern and a lot of family disruption in the home environment. So it's the sensory issues that contribute to the fussy feeding, which we talked about a little bit already, but it's what makes their diet so limited, because some children do not like really crunchy food or really soft food or really wet food or foods that are touching, so it can make feeding them really tricky. It can make things like getting a haircut very difficult, because some kids cannot tolerate the sound of a razor or scissors next to their ear or anything on their scalps. Giving them a bath can be quite difficult, because some children don't like to tolerate the feeling of water on their head through a shower head, and so getting them into a bath every night can be another challenge in itself. They can be very specific about what clothes they wear. Some kids hate wearing clothes. And just getting them dressed in the morning can be a battle, or they have very specific types of clothes they want. Either it's a really tight clothing or really loose clothing. They may not like socks. They may not like the seams on socks. And the parent really has to understand their child and be very intuitive about why their child is having such a meltdown when they're trying to get them dressed, because the child is not going to say, "Mummy, I don't like the feel of this." They're just going to have a meltdown, and the parent has to be intuitive. And this is why parenting and running a daily household can be so tricky, because of these sensory issues. The other part of the sensory issues is sensory seeking. And this can be either having a blanket that they need to have at night to hold onto and feel. It can be licking things or sniffing things before they try new foods, or while they're sitting at a table, or when they get a new object. So it's that sensory seeking as well as sensory avoidance as well. So adding to the DSM-5 criteria, so we need to meet both the social communication deficits and as well as the restricted and repetitive behaviours. These aspects need to be persistent. As I said, a lot of toddler behaviour can be seen as autism, but it's the fact that these features continue past that area of development where you expect those sort of features to decrease, and it's the persistence of that that really makes autism. It should be across multiple contexts. So sometimes we see some behaviours that may mimic autism, but it's only present when the mum is around. Whereas for the dad, we see more neurotypical behaviours, or childcare versus home, or school versus home as well. Symptoms must be present in early development, and so that's why in our screening we always look at a thorough developmental history in terms of when the child first smiled, when did they start making eye contact, and things like pointing and all those sort of things that we talked about before. It must cause impairment. So there is no point in attaching labels for a child if there is no impairment, because this is a label, once applied, it's very hard to get rid of, and it can, unfortunately, in this current society, it can hold a bit of stigma. So if it is not causing impairment and this child is functioning as they should and is happy and the family are happy and functioning fine, we need to really consider, is going down a diagnostic pathway the right choice for this family at this moment? And the deficits should not be explained by solely by other coexisting comorbidities, but I will talk a little bit more about that in later slides. So I really like this diagram in explaining autism, and it just really shows the spectrum of how and why every child looks so different. As you can see, every aspect has its more functional versus at times where it can provide more challenges. And as I said, autism can either present with these comorbidities, or these comorbidities can mimic autism. So a child with ADHD may have such difficulties with focus and attention that socializing for them is so difficult, because they cannot focus on these friendships that they're trying to make, or other children find it hard to engage with them. And so they can be thought of as autistic as well. Anxiety can make children very nervous, seek things to regulate them, like sensory things, can avoid certain situations, but they may just have an underlying diagnosis of anxiety, or they might have both together. Another big one we see in clinic, especially at Melton, unfortunately, is trauma. And this is children that have been exposed to some sort of adverse childhood event growing up, and due to having to build resilience through those sort of to those traumatic events, they can often present as features consistent with autism. And this is why a multidisciplinary diagnostic pathway is so important, to really tease apart all these comorbidities and see whether these are two or more conditions coexisting together, or is it one condition versus another? And I guess what I wanted to highlight is girls can present very differently, and due to this are often missed. Girls can superficially mask very well, and this is because they are very observant about their peers around them, and they can mimic a lot of the social skills that we see in neurotypical children, so that they don't become isolated in primary school. It might be the controlling or bossy girl who knows how to get people to play her game, and therefore she always seems like she's got heaps and heaps of friends. She can have a great imagination and creativity, and therefore parents are like, no, but she's fine, or and so she's better able to conform to society's expectations. So again, this is another scenario where multidisciplinary assessments can be quite beneficial. So what does the diagnostic process look like? So the Autism CRC, which is a national body that compiles a lot of research and best evidence, has put together a guideline that they update quite regularly in terms of the best standard in diagnosing autism. And our team at Melton Health, we've used these guidelines quite a lot to put together our process of diagnosing autism. This guideline is, as I said, evidence-based. It's very much a holistic framework, so all the disciplines and considering the whole aspect of the child rather than just their medical or their school functioning. It's individual and family centered, and it definitely focuses on the strengths of the child. And it's all about maintaining equity so that no matter which child it is, no matter what socioeconomic demographic they're in, no child will be disadvantaged by it, so that there is a stream for every family to follow. And it's a lifespan perspective as well. This diagram is a brief summary of what's in that guideline. There's a lot more detail, and I do encourage you all to have a look at it if you do get a chance. But basically, the first step of the guideline is to assess the functioning and a medical examination to make sure that we're not missing any other medical cause that might be presenting similarly. We also need to see where they're functioning. As I said, there's no point in diagnosing autism if the child is functioning well. So this is why we need to really assess what is this child's strengths and weaknesses at this point. Based on that, we can either progress to a single clinician diagnostic evaluation, and this is where there is a high suspicion of autism and where basically we just need if one clinician sits with them, then it's, BUND or autism, we know what this is. And that's usually done by a psychiatrist or a pediatrician. The other pathway is a multidisciplinary autism assessment or a consensus team diagnostic evaluation. And this can be done through combining a number of different allied health and medical professionals to understand where this child or this young person's true strengths and difficulties lie. And then all throughout this process, we need to make sure that as we are waiting for this diagnostic process to occur, that the child is not held up in the supports they receive. So if we do automatically see that there's a speech delay, instead of just waiting for that final outcome of autism, making sure that we refer early to speech therapy or get their hearing checked or whatever this child needs at this time. So I've alluded to this already. At Melton Health, we have a multidisciplinary autism assessment, and generally, COVID has changed this a little bit. We have a psychologist, a speech pathologist, a occupational therapist, and a pediatrician on the team. Because of COVID, we've had to modify this slightly, but we have at least 3 out of those 4 clinicians present in our multidisciplinary assessments. This model was established in 2007, and as the new guidelines come out, we are constantly revising this model to make sure that it reflects best practice. Prior to the assessment, we need a pediatrician review who will then refer to the multidisciplinary autism assessment. We request a cognitive assessment and a language assessment. The cognitive assessment to make sure that there's no intellectual disability that may be masking as autism, and a language assessment to give us a objective picture of what this child's speech and communication is like, and that should generally try and include a pragmatics assessment as well. We include a SIVA or Achenbach questionnaires to get a better understanding, which breaks down behaviours according to DSM-5 criteria. And we also get the family to complete a number of questionnaires, including demographic questionnaires, anxiety scales, and sensory profiles as well. So although the assessment is at one time point, so we see a child either in one morning or one afternoon, it's not that we're only meeting this child once. Generally, before the child comes in, we've had a whole wealth of information collected, which is really reflective of who this child is as a person. We generally try and speak to the school prior to these assessments as well, or childcare, to make sure to understand what they're like in different settings as well. So on the day, the child, the carer, and the allied health team and the medical team come together. We start off by doing a structured format, which is usually an ADOS-2. Again, we had to modify this slightly in COVID, but we are going back to the ADOS, which is an observational scale of autism presenting features. The family then do a thorough developmental history by the paediatrician, which is followed by a team discussion and then feedback to the family. So, as I said, the observation is the ADOS-2, which is a standardized assessment tool of communication, social interaction, play, and restricted repetitive behaviors, which are all the criteria of autism spectrum disorder. And these activities include observing the child with imaginative play, seeing how they respond to questions, seeing how they start up social interaction, see how they read into things when they're presented with images, and see if they're able to look into the underlying meaning of those images presented. And this is the kind of room that they're in. So as you can see, we've got a table with a whole bunch of toys. This setup is more for a preschooler. And as you can see over here with this mirror over here, the family, so the parents are often sitting behind that. So it's a one-way mirror. So the child is not influenced by their parent generally, if they can tolerate that. And the parent can see, which helps to explain the diagnostic process to the family as well. The paediatrician review goes through a developmental history as well as medical history, current concerns, and current assessments and services involved. And a big part of that is identifying the child's strengths. So we know how we can structure support so that we actually use the child's strengths to get them to where we would like them to be or where the family would like them to be as well. And then after the history, we give the family a break because, as you can imagine, it's a very long morning or a long afternoon. And during that time, the paediatrician will meet with the allied health and we will put together all the information that we have to formulate a diagnosis and a plan as well. Then we provide feedback to the family on the same day, and that includes, does the child have autism? What other conditions may be present, although we do not confirm any other conditions? What services and supports the child needs and how they can be accessed, and that includes funding and different pathways. We do offer a social work appointment, and if autism cannot be confirmed, and that might be because it does not exist or if we are unsure, we may do further assessments by allied health, or we might organise an observation of the child in another environment, such as a school visit or a childcare visit as well. Before we go into what I feel like what we understand the GP's role in all of this is, because I think that would be the most relevant to all of you. The other pathway that I'll briefly just talk about is a private assessment. The private assessment can be more costly to families. Essentially, a private assessment means the family has to source a private speech pathologist, psychologist, and a private paediatrician to confirm the diagnosis, and that includes at least 3 up to 6 different appointments that the family has to make sure that they attend. And then and all of those individuals, even though they may not be in the same site, they all have to communicate with each other to come to a consensus, essentially, and that can be quite logistically challenging. So as well as quite costly for the families, it can be quite logistically challenging. There are some places that do provide a similar model that we do that are private, but wait lists can be quite long as well. So, sorry, my slide is not working again. So what is the GP's role in this? And I don't want to be, preaching to the choir. I'm sure that all of you have got lots of experience with managing autism. But what I wanted to highlight is a GP's role is you are in a unique position to notice difficulties, because as paediatricians, we often just see these families like once every 6 months, maybe once every 3 months, due to it being a public service and not a lot of availability appointments. But because as GP, you have seen these children grow up from often infants all through childhood and have seen the families. So you are in a unique position to observe the child on numerous occasions, understand the dynamics within the family, and also the known history of what the parents have gone through or the carers have gone through as well. if you are concerned about the child, the first step is to commence discussions with the parents and start to explore how they're feeling or whether they have considered this or not. And as I said, understand the function of this child. Things like commencing referrals to services can be done, such as private referrals, NDIS, early childhood intervention, mental health support for the parents, carers, because as I said, parenting a child with autism can have its own challenges, which can cause further difficulties in the family, and referring to allied health therapy as well. Also addressing basic medical needs, like making sure their hearing is okay, checking if they need some physio for toe walking or contractures that might have become apparent, basic blood tests to screen for iron secondary to fussy eating, optimizing sleep to help with behavioral disturbance. Often, in terms of referral to a paediatrician, this can include whatever observations that you've done and concerns, previous therapies, and the care team involved. In terms of referral for assessment, as I said, this can be done for a paediatrician to then refer to the Melton Health multidisciplinary autism assessment, but other referrals can be put through to private therapists through a mental health care plan or a chronic disease management plan, dietitian through Melton Health, social worker, or other supports for the parents as well. The other great resource that has been developed is the Health Pathways website, which provides clinicians with a single website where they can access, which has quite a lot of this information and referral pathways and other resources that can help the families as well. These pathways are created by GPs and GP clinical leads, along with hospital-based specialists. And on this website, there are different subheadings, including developmental concerns and behavioural concerns, which have a lot of information about suspected autism. But it's also got lots of other useful information, such as speech and language difficulties, how to refer to early childhood intervention, maternal child health nurse, and allied health referrals as well. There's also a new pathway that's super exciting about ADHD in children and youth. And this pathway was helped to be written about by two experts in this field, Daryl Efron and Harriet Hiscock, who are very experienced paediatricians, and again has a really good guide to GPs on how to approach suspected ADHD in children and youth. There are lots of upcoming projects, including paediatric mental health, other mental health focused, and pathways specifically on autism, eating disorders, and wellbeing as well. So I definitely urge you to check that out. And this is the website that you can access this all at. And if you would like access, this is the email as well, which I'm sure we can put up at the end if there is. Yeah. So sorry, that presentation went a bit longer, which is cut into question time. But if you're happy, we'll open it up to some questions if we have any.
Oops. Thanks, Mandy. That was a fantastic session. Great overview. So, and it sounds like there's the service up at Melton is really quite a unique service out west. What's the wait like at the moment?
Jo, thanks so much. Yeah, that's a really interesting question. So prior to COVID, the wait was 3 years plus. We got a boost of funding just before COVID hit to increase our assessment, so we could do at least 10 a week. And before COVID, we got our wait list down to about approximately 1.5 year. Unfortunately, COVID hit and we had to suspend a lot of the services until we found an appropriate model that we could do a lot via telehealth. But we're now sitting at about 2.5 years, unfortunately. So we're trying to get back on top of that wait list.
Yeah, it's really quite difficult, isn't it?
Yeah, and unfortunately, because it's one of those few places in Victoria that so you see both preschool and primary school children, it is a service that's in high demand, and that's the wait list. When we're looking at private pathways, the wait list is more about sort of about 7 to 12 months. So again, it's not super short, but it's a little bit shorter than 2 years. Yeah.
And do private paediatricians often refer into Melton once they've done that initial assessment for that multidisciplinary session.
Yeah, we do get a lot of referrals from private paediatricians, and that's just because coordinating a multidisciplinary team can be really challenging for a lot of families, because that means they have to go and find two or three different allied health to do assessments for their child, which includes 2 visits. They need to pay for those out of pocket, and then they have to coordinate those assessments to be transferred to the paediatrician to then sign off on the diagnosis. So it can be really challenging. So this is why private paediatricians just refer to Melton Health. Sorry, the other thing I wanted to add, this is why a single clinician diagnosis in children where there is a high suspicion of autism can be really helpful for families, because getting a single clinician diagnosis is much quicker. But again, we need to make sure that we keep in mind that we just don't use a single clinician as a quick route to get a diagnosis. We need to make sure that autism is actually existing in this child.
Okay. Right. Thanks. And is Melton zoned? So
no. We accept referrals for the multidisciplinary autism assessment throughout Victoria.
Okay. So word might get out and then we might be overrun again.
Yeah, true that. Yeah.
Okay. And so if we've got kids that we suspect are, on the spectrum, and we're waiting for a paediatrician referral, what things can GPs do to help sort of get these kids engaged and try and maximise, potential as we're going along?
Yeah, so I think that really depends on the age of the child. So if it is a preschooler, getting them linked in with early NDIS and early childhood intervention is key, and that's a simple online form that the families can fill out themselves, and just guiding the family on what sort of goals they might need to advocate for their child, and that might just be independence, communication, and things like that. For early childhood intervention and a key worker, the wait list is about 2 or 3 months. So that can happen, really quickly, because this is what the NDIS's aim is all about. So getting them involved in that so that they can start accessing therapy even before they see a paediatrician. So that's a big part for preschoolers. For primary school age, it's a bit more challenging, but using mental health care plans and chronic disease management plans to get them into private therapy can be useful. Making sure that the school is supporting them, so making sure that the school is doing everything that they can, including tutoring, regular meetings with the families, using whatever schools have lots of resources on managing suspected autism, so making sure the school is supporting this child. And yeah, that's that in a nutshell.
Okay, great, thanks. There's another question here. Can the single clinician be a psychologist or a speech path, or does it have to be a paediatrician?
That's a really good question. So there is varying acceptance by different bodies. So Department of Education generally want a paediatrician or a psychiatrist before the school will get extra funding to support these children. So this is why we recommend a paediatrician or a psychiatrist. For things like NDIS, a psychologist who has done an ADOS and an ADIR for the child might be enough to get the child over for NDIS. But yeah, so a single clinician, we generally recommend a paediatrician or a psychiatrist because of schooling, but a psychologist can start off the NDIS.
Great, thank you. I'm just working through some of these questions here. Question, how to manage undiagnosed childhood ASD in an adolescent who present mostly with behavioural issues? Is it too late to help adolescents who are not diagnosed early?
It's not too late at all. Autism can look very different throughout the lifespan. So I think getting them into a paediatrician ASAP would be the first step, and then that can just often proceed to a private pathway, to get the adolescent diagnosed. We have lots of families that come in to get their child diagnosed, but then recognise features in themselves. So adults who start to feel like they might have autism, and then they go down the pathway of getting themselves diagnosed and supports as well. And I think it's so important because then they understand their own strengths and challenges as well. And yeah.
Thank you. Another question, how can we do a mental health care plan or a GPMP if we don't have a diagnosis? Do we just put a formulation of behavioural difficulties or speech, or for example, speech delay?
I'm not sure about the technicalities of a mental health care plan, because as paediatricians we generally don't do them, but in letters that I have done for mental health care plans, I basically just outline the difficulties for the child. So yeah, either speech delay or behavioural challenges or social difficulties.
I think often these kids have got significant anxiety, and so I guess that's a diagnosis that we can put on a mental health care plan, trying to get assistance for them. How can parents with autistic children be supported? So what support organisations are there available?
Yeah, so the Amaze Victoria website is really excellent. It has different subsections for the children, for adolescents, for adults with autism, and for parents and carers of autism as well. On there's lots of YouTube, lots of videos explaining about autism. There's lots of different parent support groups on there. There's resources that families can do some reading into. So that's the first step. There's also, as I said before, getting a mental health care plan for the family or the parent can be really helpful as well, because a lot of these families take a lot of the blame and guilt for their child's presentation and difficulties on themselves. And then therefore they can get quite frustrated or resentful for the child as well. So making sure that the parent or the carer's mental health is looked after as well. And then parenting programs. There's lots of online parenting programs, such as the Triple P parenting, which can be quite beneficial as well.
Great, thank you. And what about the challenges with families who are non-English speaking backgrounds, and how are you working with those?
Yeah, so this is why we use our administration and other allied health so well. So with our non-English speaking background, we often do use an interpreter as part of the assessment. So that's an interpreter as part of the ADOS, and in terms of the history as well. We also find that these families can find that navigating support pathways for autism really challenging. So we also ask the family if they'd benefit from a social worker appointment, which is again supported by an interpreter. And this is why a social work can be so helpful, because it just helps these families navigate what can be a really complex system.
Great, thank you. Another question, what support is offered to the adolescents if they're diagnosed late in the adolescent age group?
Yeah, so it's a really broad question, because it really depends on what challenges they're having. With a lot of adolescents, I see the most common presentations are mental health difficulties, so anxiety and depression, so making sure they're supported by a psychologist. We also get a lot of school refusal and selective mutism, so making sure that they're linked in with programs through school and Department of Education, such as the Navigator program or the FLIP program, which is basically an off-site learning program. You can do things like, equine therapy, and then the other thing for adolescents is, making sure that their future is you start planning their future. So really exploring their interests, what their passions are, and how do we use those interests to get them to be a functional part of the community. So can we get them involved in, work experience? How do we support them with going for job interviews and working with team and working on all of those skills that are going to get them functioning in the community? So rather than learning and socializing, we focus more on function. Yeah.
And I think for those people, sometimes once they've been able to access the NDIS, some of those other supports then open up. I think it's the delay in accessing it, isn't it? Yeah. Just looking to see if there's any other questions. I think I'm at the end of the questions. Thanks, Mandy.
No problem.
All right. Anybody else got any other burning questions for us before we wind up? No? Okay.
We've got 1 minute to go.
No. Thank you for coming in. I think it's been a fantastic overview, and I think encourage everybody to look at the health pathways, because it does have the health services referral criteria and prompts you to provide all that information that is going to make it easier to get that patient seen. So
yeah,
and I think the other thing I just remind people is that often the schools have access to speech therapists and psychologists. They sometimes won't tell people, and my experience has been that sometimes they'll say, you know, oh, we'll go to the GP and, you know, get this or get that. But when you actually push the school, they do have them available. So I think that they're a really good resource to be using as well. And they're able to do a lot of those initial assessments and work with the school while you're waiting for paediatrician appointments and things.
Yeah, as I said, schools have often got lots of supports in place. So they've got wellbeing support coordinators, speech therapists. They often run social skills groups. You know, there's lots that the school can actually do. And that's why, so while you're waiting for, you know, a diagnosis, it's often good to get the school on board as well.
Great. Thank you, Mandy. I think there's a question here for Phil. Have we got a recording of this that will be uploaded? Yes, so it'll be on the PHN website. So you'll be able to contact them if you have difficulties, but usually they're pretty good at getting up on their YouTube channel quite quickly. Great.
Yeah,
thanks,
fantastic.
Mandy.
And I think, yeah, thank you so much, Mandy. That was a brilliant presentation, and thanks, Joe, for facilitating those questions. And yes, thank you everyone for attending. I also want to thank the Northwest PHN for supporting us with this webinar this evening. We're very appreciative of all your support with Western Health Education. So thank you. And I just wanted to let you all know to stay tuned. Our next webinar is on the 25th of May at the same time, 7 p.m. This one's titled "Help, She's Pregnant, What Do I Do Now?" So that one's coming up. I think that's up on the PHN website already, and I'll send a link out to register tomorrow as well. So thank you everyone again. And yeah, I hope you really enjoyed it, and have a fantastic evening. Thank you.
Thanks so much, Joe.
All right.
Thank you. It took a while.
Took a while, didn't it? Then the detach button.
The world's longest communal logout.
Yeah,
I know.
yeah, I
Like,
think so.
geez, most people are like quick to leave. I
Yeah.
hope that was okay.
Oh, that was wonderful.
so
It was
good.
excellent.
Yeah.
Yeah.
I think I talked a little bit too long, so I'm sorry.
No.
It was actually perfect
really
because I
good.
think that the questions ended at the right time and just in time for us to finish up. So
Very good.
Thank you for
All
giving
right.
me this opportunity.
Oh, thanks for sharing your knowledge. It's gone really well. Yeah.
No,
It's always
yeah.
hard to get pediatric ones. Yeah.
Yeah. Well, hopefully we can do a few more of them this year. I know my boss, Trupti Prasad, who's the director at Melton Health, she has one on ADHD ready to go. So hopefully,
good to know.
Hopefully in the next couple of months when a time that suits can be figured out, she can do her one. So yeah.
And I'm always happy for you to sort of nudge me as well if you want to say, hey, let's get something happening, and then we can
Karen's been amazing at that. She's been really proactive in organising, and I think hopefully when she's feeling better, we can get that next session up and running. Thank you.
Yeah, that's right. It's just a real pity she wasn't able to do tonight, really, because then she could have shown her face on here. But anyway, it is what it is.
Yeah. All right.
All right.
Thank you so much.
All right. See you then.
Thanks, everyone.
Thanks.
Bye.
Thank you,
Bill.
everybody. Really appreciate
Bill.
it. And
See you later,
we'll make
bye.
sure this is up on the website soon. Okay.
Fantastic.
Great.
Thank you.
Thank
See
you.
you. Bye.
Have a good night. Cheers. All the best.